Fit for dermoscopy. Welcome to this next episode in the basics. And this is called Management Decision of Malignant and Benign Skin Lesions. Yeah, what does it mean, management decision? Lesion looks nasty, so we would say cut it out. Or it looks fine, so we would say it's okay, it can stay in the patient. Yeah. But is it correct that we all are better in the management decision compared to the correct dermoscopic diagnosis? So let us move into this question. Yeah, so the patients are coming in, we are listening in which lesion you are worried about. This is my main important question to the patient. And we all know that the self-detection rate is increasing, still ongoing increasing based on the patient's partner's family doctor, GP, etc., etc. So the self-examination is very important. This is an issue. And also we all know that the risk of malignancy is correlated to the age. The older patients have a higher risk for any malignant skin lesions. Yeah. And also when we checked it by eye, and we can also check it when we are palpating it. And I will go into the details on the first and next episodes in the future. For example, very important is the actinic keratosis here on the button, listed on the button. They are flat but distinctly rough. Yeah, so a little bit like sandpaper. When you touch it, you can just diagnose this in the dark, the actinic keratosis. So the issue when we take the dermoscope, yeah, this is the early detection of a malignant skin tumor, and especially of the melanoma. And also, and this is very important to say, to avoid unnecessary excisions of benign lesions. Yeah, and this is the issue when we are doing the examination of lesions of total body skin examination, etc. So then when we do this examination at the end, we come to the conclusion. So today everything is fine, and keep going. When you notice any change of shape or color, then please ask for the next appointment. Or you say, and this isn't a management decision, oh, it looks nasty, we need to cut it out. Yeah. In the management decision, just in between for the local treatment or re-image in 3 months, it is a little bit tricky, but I just mentioned it here. We need it later on. So I show you 5 lesions now, and just for you at a glance, what would you say? It is benign or malignant? Yeah, so this lesion looks for you benign or malignant? Yes, it looks benign, it looks fine. The next lesion, in contrast, it looks nasty. Yeah, you would say, cut it out. The third lesion, oh, it looks nice. Yeah, it's benign. Okay, it's fine. And the next one, oh, we need to cut it out immediately. Yeah, so yeah, and this is a management decision. The last lesion here looks a little bit. When you have seen several lesions of this, you would say immediately it looks benign. It is a SEPK. So for what we are looking in a management decision, we look for the shape, we look for the colors, and not really for the clear dermoscopic features. Yeah, this will be the next step. So we have this algorithm, and so in this algorithm we conclude now the symmetry or the asymmetry of the lesion outside of the shape, but also inside of the features. Yeah, so symmetry more and less. Yeah, not always, not all the things are very symmetric in biology, also of the benign lesions, but more and less. Yeah, so it looks fine. And one example here is a little bit asymmetric, yes, but the features, the color, all this is symmetric, yeah. So especially inside, so this is a benign lesion, so benign nevus, yeah. And in contrast, yeah, this lesion, so this is a graph. Now, when you have any asymmetry in one or two of the axes, yeah, then you would say something looks wrong, yeah. And have a look to this lesion, yeah. And this is not symmetric. This is a clear asymmetry going up to this area A, and D, and is less pronounced in B and C. So we have asymmetry, yeah, in the features of the shape and in the colors. Yeah, so it looks not nice. So we need to cut it out. Yeah, it was a melanoma in situ. So here with these features, with the shape and the features inside, we can say it looks nice or nasty, and then we need the operation, or it looks fine and you can go home. And also we include the colors, and this is important also. When we see many colors, something goes wrong. But also if you see only one single color, especially red, blue, black, or also pink. Pink is an alarm sign, yeah? Then we need to do something. Some examples, yeah? Here, clear asymmetry, yeah? Flat single lesions. Look also to the age, 64, yeah? Asymmetry, black, yeah? What? It is not a nice, good lesion, so we need to cut it out. It was a melanoma in situ. Early detected. Well done, yeah? Next lesion, nodular, yeah? Age 58, yeah? Nodular single lesions, and when you look in dermoscopy, asymmetry, blue, gray, pink. Pink is the alarm sign, yeah? And then we need to cut it out. So it's invasive melanoma in advanced stage, yeah? And also here, 46-year-old, yeah, flat. And very important, yeah, flat single lesions, and it's symmetric, absolutely less red and brown, but inside the different types of vessels, and we will talk about vessels later on, yeah. But this is an alarm sign, yeah. And look, it is symmetric, yeah. Very important. 25% of the amelanotic melanomas are symmetric, yeah. And this was an invasive melanoma. So important, yeah. Take care of these reddish lesions, single reddish lesions, flat or nodular, yeah. And always exclude here the melanoma or malignant other skin tumor, yeah. So then we have this algorithm here, and in this upper part here, we have our management decision, yeah. We do not name correctly the diagnosis, malignant or benign, but we have the management decision, cut it out or not. And for example, in this lesion, so a trunk, 48-year-old, nodular singular lesion, symmetric, but black and blue. And there are some dermoscopic features, white lines. This is our next alarm sign. Yeah, this was an invasive melanoma. Yeah, and to the management decision, we include now also the dermoscopic features, which brings us to the dermoscopic correct diagnosis. Yeah, and so from this step, from the management decisions, and we all know that we are better in the management decision compared to the correct dermoscopic diagnosis. But, and this is important, yeah, we need both. And herefore, based on this is not enough when we are using dermoscopy. Yeah, we need to name the correct benign diagnosis. Yeah, for the patients, for us. Yeah, in the malignant diagnosis, sometimes we fail, but we say it is malignant, but we cannot name the correct dermoscopic diagnosis. But in the benign diagnosis, we must do this. And herefore, we need our dermoscopic diagnostic eye, and here with all the malignant diagnosis as well. And herefore, we need in this section fit for dermoscopy. Now, the next series, and I've called this dermoscopic diagnosis based on the diagnostic eye. And so I'm looking forward to see you here in this next series. Thank you and bye bye. Fit for dermoscopy.